It's a great pleasure and honor to introduce David Tuckman. David's a great friend, awesome surgeon, and always gives fantastic talks. So I've been looking forward to learning all about the management of median nerve compression. David, when you're ready, please go ahead.
Great. Can you guys see my slides?
Yes.
Good. All right. So I'm going to talk about management of median nerve compression. I just want to say, it really is an honor for me to talk, have you on a panel with my hand surgical mentors and heroes. So definitely appreciate the invitation. So let's jump in. So I'm going to talk about both carpal tunnel as well as pronator syndrome. So carpal tunnel is really the most common compressive neuropathy of the upper extremity. Incidence about 1 to 3 cases per 1,000 per year. Prevalence about 50 cases per 1,000 per year. With an economic burden of $2 billion in 1995 money, you can imagine what that is today. Risk factors, probably one of the most common is diabetes. You have hypothyroid, rheumatoid and other inflammatory conditions, obesity, pregnancy, age, and female gender. And what is not on this list is repetitive use of a keyboard. I don't think that carpal tunnel syndrome is caused by repetitive use, no matter what you can Google and speak to everyone, but I do think that carpal tunnel can be exacerbated by. For anyone knows Steve Green, I would ask him to tell you the story about how that actually started. It's actually a very interesting story. Steve said, spoke about doing nerve tests. I think it's important that not all patients need nerve tests. Carpal tunnel really is a clinical diagnosis. We make the diagnosis on exam. Nerve tests, the problem is that they are really very operator dependent. And as Steve said, a negative test doesn't mean that someone, doesn't have carpal tunnel. But, the nerve test can be normal in 8 to 20% of patients with clinically and surgically proven carpal tunnel. And as well, they really don't correlate with outcome. Steve said as well, ultrasound is actually becoming more popular and is kind of being studied more. And if you look at the change of the median nerve cross-sectional area, it does correlate with severity of carpal tunnel. And there's studies to show that a change in cross-sectional area of 2 millimeters above the carpal tunnel and within had a 98% sensitivity for picking up carpal tunnel. Has obviously the advantages, it's much cheaper, as well as any time you can not stick needles into someone and zap them, I think they'll be much, much more comfortable. Does have the disadvantage of all of the other, issues with ultrasound is that it really is very operator dependent. Or non-operative treatment, splinting does work and it is effective in patients that have carpal tunnel for a short period of time, typically less than 3 months. Injections of cortisone are an option. 80% have short-term relief. 22% are symptom-free at 12 months. For me, I use injections of cortisone when the exam is equivocal. Do they have cervical radiculopathy and carpal tunnel? Do they have diabetic neuropathy and a compressive component as well? Giving injection of cortisone will give you a very good prediction of how they're going to respond to surgery. If they don't get a good response from the injection, they're probably not going to get a really very good result from surgery. I do use cortisone actually in women who are pregnant, typically in their third trimester, and they're absolutely miserable. You can give injection of cortisone. You can hold them off until they deliver, and then the carpal tunnel typically goes away. Medications, nothing works. Nothing's really been proven to be beneficial. B6, gabapentin, NSAIDs, unfortunately, nothing works. I think it is worth a short discussion about acute carpal tunnel syndrome, which is related to trauma, typically distal radius fractures and carpal dislocations, case reports of acute carpal tunnel from hematoma blocks. You can get acute carpal tunnel from wrist position, kind of post distal radius fracture reduction and casting if the wrist is placed in extreme flexion or extension, which you definitely do want to avoid. I think so. If you would look at the presentation, so you have the patient that falls, they injure their wrist, and instantly their hand is numb. That is a traction neuropathy that is not an acute carpal tunnel. Typically, the acute carpal tunnel patient comes in with a normal exam, and then slowly that nerve starts going out. You have a progressive, you have a progression of the exam as well as they have pain. Whether it's emergent or urgent, you have to do it in the middle of the night or the next day. There is good data to say that you can wait until the next day with basically equivalent results. That being said, I would probably take them the same night. I probably don't want to sit on an acute carpal tunnel. Really our kind of big concern when you're talking about carpal tunnel surgery is the thenar motor branch variance. And if you look at the Lance classification, you have group 0, which is basically kind of the typical textbook anatomy where the motor branch, branches right after carpal tunneling, and it goes straight radial. It would be great if every patient had this. Unfortunately, there are a significant number of variants, and really the variants are what keep us up at night in terms of not injuring the nerve. And there are variants of the thenar branch itself. There's accessory thenar branches. There are high divisions of the median nerve. There are proximal accessory branches, and a lot of these are kind of interesting if you're doing an anatomic study. But if you're actually talking about carpal tunnel surgery, there are a couple that actually you really have to know, and you really have to be very, very careful about. And it's really these four, and it's really the conjoint where the motor branch branches early, goes through transverse carpal ligament, and then rejoins. The ulnar word, that actually the nerve branches and goes off from the ulnar side of the nerve, then comes superficial, and then innervates the muscles, and then there's a supraligamentous, and then what is not in the Lance classification is the pre. Now, and I think the key is you just have to be very careful. You don't really want to be very aggressive. You want to make sure you take your time, and you want to always be looking for these variants because not everyone is a normal thenar motor branch. And I think that's really very, very important. Like this was my case. You can see that this is most likely an ulnar word where the nerve comes off ulnar, comes superficial, and really the key is you have to identify this. You have to obviously protect the nerve, and just the key is just being very careful. So obviously there's always a big debate. You want to do this, open? Do you want to do it endoscopic? We do know that there is an earlier return to work with endoscopic. There are recent studies show there's really no difference in complication rate between the two. And the results of the two are really, pretty much equivalent after about 3 months. Just kind of from my own experience, I've been in practice for about 15 years. My first 7 years in practice, I did these all open, and then I transitioned to endoscopic. And I'd say the big difference that I've seen is that, when I was doing them open, I would see the patient back at about 10 days, and I'd say, look, if you're fine, you don't have to come back. You can go back doing anything you want to do. 10 to 20% of those would bounce back and see me at about 6 to 8 weeks later, and just with a complaint of just being sore. And obviously, reassure them you're going to be fine, it's going to get better. When I switch to endoscopic, the bounce back rate is almost zero. Now, they all end up at the same place, but I think the endoscopics just get there faster. You do have the option when you're talking about doing an endoscopic release. You can do either a mobile cannula or you can do a stationary cannula. This video shows, and hopefully it plays, the video shows a mobile cannula. And I do have concerns with this in that you're basically bringing the whole cannula in and out. And I have concerns that, you can have a nerve that can kind of pop in and you won't notice and you can cut it with the blade. I personally prefer using a stationary cannula. This is a dual portal system. It has one portal as a viewing portal. One is a working portal. Most important thing is that the cannula stays where it is. Procedure done under local sedation. There's always a nice wrist crease which you can use. You can hide the incision. And you want to be careful. You don't want to kind of pound through the skin. You want to just come through skin, spread straight down to to the volar forearm fascia. And you can see it kind of has these transverse fibers. Then you want to do the proximal release. I always do the proximal release first, and then come through the volar forearm fascia. As soon as you see fat, then you know you're done. And then release proximally. And you don't really have to go very far, maybe half an inch, and then you want to start releasing distal. And you want to kind of free and release the median nerve from the undersurface of transverse carpal ligament. You want to release, pretty far distal, because as soon as you extend the wrist, the incision does tend to kind of translate a little bit distally. So you want to use roll towel, extend the wrist about 45 degrees. All systems are basically the same. They basically have progressive dilators. You want to kind of stay ulnar. You kind of hit the hook of the hamate, and that kind of brings you in. Then there's a rasp that kind of just cleans up the undersurface, and you want to start basically midline, and then you want to go ulnar. You don't want to go radial. Cannula then goes in, and then the camera goes in, and you can see you really get a great view. You do want to take a very good look. Make sure that you don't have a nerve sitting there. You want to make sure there's no tenosynovium on top. And it's very important. So my right hand is only doing tilt and is not pulling. I am pushing actually with my left hand. My left index finger is pushing. And it's very important. You want to use your intrinsic muscles of your hand to have much more fine motor control than your arm muscles pulling. Full thickness cut, about 75% of the length, and then you go back as many times as it takes to complete it. Usually twice is enough. And then you want to bring that proximally. As soon as you see fat coming down, you know that you're through. And then you complete it, and camera goes back in. As soon as you see those longitudinal fibers, those are fibers of the palmar fascia, you know that you're complete. Little band there, just go back in, complete that, and then you're done. And I close this with intra-buried sub-Q 5 monocryls, Dermabond, and a Steri-Strip. It really does give an amazing cosmetic result. That incision basically will disappear after about 6 months. So my post-op, I do the same post-op for carpal tunnel, triggers, Dequer veins, mucus cysts. I stopped giving narcotics about 3 years ago. I just give Aleve, 2 tabs twice a day, Tylenol. They can mix in Tylenol between or at the same time. We know that splinting and casting for carpal tunnel is not only not necessary, it is actually can be detrimental. Therapy for post-op carpal tunnel, definitely not necessary. So let's go to Pronator Syndrome. Pronator syndrome is a compressive neuropathy of the median nerve at the elbow. I don't think Pronator syndrome is a very good name for it because while pronator is the most common, it is not the only site of compression. The signs, you typically have these kind of vague aching pain in the proximal forearm. You do get paresthesias as well in the median nerve distribution, pain with activity. There are 2 different presentations. You can have more of a chronic presentation. You can also have patients that have an acute presentation, young, involved in sports, weightlifting, and they tend to have a more acute presentation with significantly more pain. If you look at our sites of compression from proximal to distal, you always, with every one of these patients, you do want to get an x-ray of the elbow. You're looking for a supracondylar process, which is basically a bony protuberance off the distal medial aspect of the humerus, and you get basically a ligament of Struthers, which is a fibrous band that goes from the supracondylar process to the medial epicondyle. The median nerve will go below, and the brachial artery can go either above or below. And I think it is very important to remember that you can get a ligament of Struthers without a supracondylar process. So having a negative X-ray does not mean that is not a potential site of compression. Next, if you go distal, look at Lacertus. Lacertus is a fibrous band that goes from the distal biceps, kind of fans out medially over the flexor pronator mass, and the median nerve goes under this. You can get compression of the median nerve with the form as the form goes into pronation. It draws Lacertus kind of distal and deep. There, interesting study, Journal of Shoulder Elbow, 7 young patients with an acute flexing injury. They had severe anterior proximal forearm pain, and the Lacertus was a primary compressive source. Pronator, there are 2 heads of pronator, superficial and deep. The median nerve will typically go between those 2 heads, but there are some variants of that as well. It is the most common site of compression, and you do get these, kind of thickened intramuscular bands within pronator that can be the site of compression. Then the last site of compression is this kind of fibrous arch of the flexor digitorum superficialis that can put pressure on the nerve as well. On exam, you get a Tinel's, but only 50% of patients have a Tinel's. You want a Tinel's over the proximal extended proximal run of the median nerve. There's a compression maneuver, kind of like a Durkin's of the wrist, in which you put pressure over the median nerve, about 4 centimeters medial, 4 and 6 centimeters distal to the medial epicondyle. You can kind of also do a similar thing where you kind of use all 4 fingers and go over the entire course of the nerve. Motor exam, typically normal. And then I think really the question, and a question I would actually like to ask the panel as well to comment on afterwards is, can we pinpoint our site of compression and tailor our surgical release based on our physical exam, and specifically provocative maneuvers? So you can look at Pronator Syndrome. You can look at pronator as a site of compression with the elbow in extension with resisted forearm pronation, looking for reproduction of paresthesias. FDS, resisted PIP joint flexion of the middle finger. You can look at Lacertus with the elbow flexed at about 100 degrees with resisted forearm pronation. Our diagnosis is really purely clinical. It's based basically on our physical exam. Nerve tests, not really reliable. Vast majority are normal. You do want to differentiate it from carpal tunnel syndrome, and whenever you think of carpal tunnel syndrome, always think about pronator as well. If they've kind of any pain in the forearm, you always want to examine for pronator. Treatment, activity modification. If they're doing a specific activity that bothers them, obviously they should avoid that specific activity. Anti-inflammatories, maybe. Pronator stretching, FDS stretching, maybe. Corticosteroids, a big maybe. 50 to 70% improve by themselves, kind of eventually. And if not, then obviously we talk about doing a decompression, and we have 2 options. We can actually have more than 2 options. So we can do a complete, where you basically releasing all 4 sites of compression with good texting results, 71 to 93%, or we can do a limited release. We're just releasing those specific sites that we are specifically concerned about, with really, based on the current data, very similar results. There's are just descriptions of an endoscopically assisted release, where you make a small incision and use a scope, and the pictures are very interesting. I personally do have concerns about using an endoscope for this, because we're not doing a lot of this, a lot of these cases. And to get on the right side of the learning curve, I think you're going to take you a very long time to get there, if ever. I personally prefer to make a little bit of a larger incision and just make sure you're safe. I personally would do a kind of like a hybrid between the 2, do more of a mini open, go between pronator and FCR. I kind of release as far distal as possible. You do ideally want to release the FDS as well, but again, questions about tailoring your release based on your exam. and you just want to, anything that's putting pressure on the nerve, you want to take that pressure off the nerve. Thank you.
All right, David, thank you. That was a great talk, as always. While we're loading up Dr. Posner's talk, I just wanted to say I usually go big on the Pronator release.
Yeah, you know what? I have concerns about going small because you know what? The problem is that if someone doesn't do well and you do a small incision, or they do well just because it's a different diagnosis, or did they not do well because, well, actually they did have a ligament of Struthers that was actually the source of compression, and doing a small incision, you aren't releasing it. So, yeah, I definitely agree with that.
All right, fantastic. Thank you.